Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausmann. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcasts, Spotify, and on your favorite podcast app. I came of age at a time when ultrasound was just starting to be offered within rheumatology fellowship training programs. But unfortunately, I failed to take full advantage of the opportunity to learn how to perform musculoskeletal ultrasound. Since then, I've sort of developed a love-hate relationship with ultrasound. I mean, I love it when I refer my patients for MSK Ultrasound and my colleagues use it to make diagnoses of inflammatory arthritis or crystalline arthropathy, or when they leverage ultrasound to accurately inject joints, tendons, and bursae. However, sometimes I hate ultrasound because it makes me question my physical exam skills. Imaging studies sometimes reveal synovitis when I didn't expect to find any, or they reveal its absence when I did. At the same time, I have a little FOMO at the fact that some of my colleagues became trained and certified in the use of MSK ultrasound, while I did not. But anyways, that's neither here nor there. In today's episode, we've invited an ultrasound expert, Dr. Minna Kohler, to discuss the use of ultrasound in rheumatology. We begin with its use for diagnosis, including in inflammatory arthritis, crystalline arthropathy, and vasculitis. We'll also discuss various ways in which ultrasound can help therapeutically. We discuss the workings of an MSK ultrasound clinic, how you can become trained in ultrasound, the patient experience, the use of handheld devices, and the use of ultrasound internationally. We discuss controversies about the use of ultrasound in rheumatology. And finally, we finish the episode by predicting the role of ultrasound in the future. Dr. Minna Kohler is the founder and director of the Rheumatology Musculoskeletal Ultrasound Program at Mass General Hospital. She completed her rheumatology fellowship at Yale University School of Medicine. She's also been very involved in ultrasound education, both locally, nationally through US Sonar, the Harvard MSK Ultrasound CME course, and through the ACR. We recorded this episode live in person in the basement of the Massachusetts General Hospital, so it may sound a little different than what you're used to hearing in other episodes. Nevertheless, I think it was a lot of fun to record, so I hope you enjoy it. Minna, welcome to the show. You know, it's not every day that we actually get to interview somebody in person.
Thank you so much for having me today.
For listeners, can you tell them a little bit about where we are today?
We're at the Mass General Hospital in the Bullfinch building. It's a very historic building here.
Yeah, I believe they have the Ether Dome right upstairs where anesthesia was first used. So we're here to talk about not the history of medicine, but about ultrasound use in rheumatology. I understand that you came to rheumatology and ultrasound in quite a roundabout way. Can you tell us more about that?
Yeah, that's right. So when I was a medical student, I really enjoyed all different aspects of medicine and had a difficult time choosing a specialty. But I did enjoy procedures, and I actually went to surgery residency first, where I did 3 years training. And then at that point, I decided it wasn't for me and moved to Boston to do an image-guided therapy fellowship in radiology. Then within radiology, I grew my love for imaging. However, I really missed seeing patients. I couldn't be in the dark room. And so I went back to internal medicine training. It was at that time that the Europeans in rheumatology were beginning to discuss the use of point-of-care ultrasound within rheumatology. Having had an anatomy, surgical, and radiology background, I was fascinated with how imaging can assist with diagnosis and monitoring of our rheumatic diseases.
What a crazy story. So you did surgery, residency, then a fellowship in radiology, and then you had to do what? Internal medicine residency, and then rheumatology fellowship?
Correct.
Oh my goodness. And then did you have any additional training in ultrasound, or did you think that your experiences with your radiology fellowship were sufficient?
So I first had exposure to ultrasound actually as a surgery resident when we were using it for the FAST exam. And at that time, it was actually quite new. The ultrasound machines were large, bulky. The imaging was very grainy. There was not full adopted use as it is today in trauma surgery with putting the ultrasound probe immediately at the bedside in the emergency department. So fast forward within radiology, I actually didn't do any diagnostic ultrasound, but was involved in research with focused ultrasound surgery, which is actually a different application of ultrasound that uses ultrasound at high frequencies for ablation.
Oh, fascinating. Very good. So tell me a little bit about how you use ultrasound in your rheumatology practice and specifically for diagnostic purposes. Where do you think ultrasound is most helpful?
I don't know if you're aware, but in 2008, the ACR actually had a white paper on the reasonable use of musculoskeletal ultrasound. And it actually goes through different diagnostic scenarios where point of care ultrasound can be helpful in rheumatology. Those include the clinical exam that is ambiguous. So, for example, if you have a patient who you're uncertain that there's joint inflammation on the physical exam or tendon swelling, but clinically, it sounds like there may be an inflammatory component. This is where ultrasound can be helpful in confirming or denying whether there's presence of synovial thickening, inflammation, or hyperemia as evaluated by power Doppler, and the presence or absence of effusions that may be amenable to aspiration that can further guide your diagnosis. Also, ultrasound is known to be highly improved in identifying erosions earlier than X-ray. If you are suspicious that you have an inflammatory arthritis patient that may be having bony damage, but the X-rays are not yet revealing it, ultrasound can be your earlier window to seeing damage.
Got it. So it sounds like for patients, initially that you're unsure whether or not they may have an inflammatory arthritis, it can be useful also to see if there's bony damage because they have an increased sensitivity. I know that we're using it here also for diagnosis of giant cell arteritis.
Yes, ultrasound can be used for large vessel vasculitis, specifically the temporal arteries and supraaortic vessels. Certainly, if you have a patient with a high clinical suspicion for giant cell arteritis or temporal arteritis, a lot of patients may not necessarily want to pursue the surgical biopsy. So you can consider a diagnostic ultrasound of the temporal and axillary arteries to evaluate for the halo sign, which is the thickening of the intima media in a homogeneous pattern.
Got it. And then also, I guess, for diagnosing PMR, it's recommended, or at least I think you get some bonus points if you see some abnormalities on ultrasound.
There's been several guidelines looking at ACR EULAR criteria for ultrasound use, and those conditions include polymyalgia rheumatica, gout, and large vessel vasculitis. Specifically in polymyalgia rheumatica, the ultrasound findings that we often see are biceps tenosynovitis in the shoulder, subdeltoid bursitis, and then also in the hip synovitis and trochanteric bursitis. However, these imaging findings can also be seen in other inflammatory conditions such as rheumatoid arthritis. So the clinical scenario and correlating clinical findings is very important. Now, the classification criteria for use of ultrasound with PMR was designed for research purposes, not necessarily clinical, but in a clinical scenario, one way you may think about using ultrasound for polymyalgia rheumatica is if you have a patient who sounds suspicious for inflammatory symptoms that you might think is polymyalgia rheumatica, but say their SED rate is normal. then ultrasound could be helpful in identifying inflammation at the local regions to kind of help clarify the diagnosis. Additionally, there's mimickers with polymyalgia rheumatica, including CPPD. The ACR-ULAR classification criteria for CPPD just recently got published, and use of ultrasound is recognized for identifying crystal pathology. Some of these patients that we're actually diagnosing as polymyalgia rheumatica may in fact actually be CPPD, or maybe a combination of both polymyalgia and crystal arthropathy.
Amazing. I think the coolest thing for me about, sending some of my patients to you for crystalline arthropathy is that you can actually see the crystals on ultrasound, and you can differentiate between MSU crystals and calcium pyrophosphate crystals.
To clarify, definitely ultrasound for the diagnosis of gout is highly helpful. And you can actually diagnose this even when the patient is not in a flare. If you have a patient with hyperuricemia, their flare has already passed, but you're highly suspicious that there's still gout in the diagnosis, you can apply the ultrasound probe to the joint that was previously flared, and you may see that pathognomonic double contour sign or hyperechoic aggregates that are described as sugar and water appearance. So the gout crystals are much finer in appearance than CPPD crystals, for instance, which tend to be larger and more rounded in appearance.
Super cool, because if you had a patient with acute gout, traditionally we'd want to aspirate that joint, but we often see these patients later on after the episode has occurred. What a great opportunity to put an ultrasound there and convincingly diagnose gout just based on imaging.
Now, sometimes you will see crystals, and it will be difficult to differentiate between gout and calcium crystals. Certainly, gout and calcium crystals can coexist. And since calcium crystals are larger than gout, and sometimes you'll actually even see calcified tophi, that's when actually ultrasound is also helpful in discerning small joint effusions that you may not necessarily appreciate on the clinical exam, so that you can do an ultrasound guided procedure to aspirate that small sample of fluid.
Amazing. So you've mentioned various reasons why we may want to use ultrasound, but I always wonder about, when should I choose ultrasound over something like an MRI or a CT scan? What do you think are some of the advantages of ultrasound as compared to other imaging modalities?
So advantages of ultrasound is that it's in the clinic. So it's much faster to obtain the answer. It's cheaper than cross-sectional advanced imaging such as MRI and CT. Ultrasound is also the number one imaging modality for tendon pathology. Not only does it show whether the tendon is intact, but it shows that fibrillar pattern of the tendon and can discern tendinosis or degenerative tendon change and subtle partial tears that may not necessarily be visualized on MRI. Ultrasound is also very sensitive in picking up erosions. As I mentioned earlier, it can pick up erosions much quicker than X-ray. The disadvantages or limitations of ultrasound is that it does look only at superficial structures, so it doesn't necessarily show bone marrow edema. You don't know what's happening beneath the bone. You can only visualize what's above the bony surface.
Are there any instances where you would recommend that we don't refer patients for musculoskeletal ultrasound? I mean, I'm wondering about patients with whole body pain. Any other places where you think ultrasound may not be the preferred imaging modality?
Point of care ultrasound usually works best when there's a specific clinical question in mind. We don't have time to scan the entire body. If you have a specific joint region that you're concerned about, is this an inflammatory process? Is this a mechanical process? Or maybe there's some central pain involved, then that's when you may want to consider ultrasound. Do I use ultrasound for every single rheumatic patient I see? No. Certainly, clinical judgment is number one. But if your clinical assessment is not clear, you feel you need imaging to further clarify what's going going on. A good example would be a patient with rheumatoid arthritis that you've started on biologic therapy. They seem to overall be improving except for this one joint region. And then your question is this just a really refractory area of inflammation? Have they mechanically injured that location? Or is this just a completely different process? So before escalating treatment, you may want to apply ultrasound to really confirm, is this inflammatory pain or did they actually have an occult fracture?
Fascinating. And then you also hinted at ability to tell about tendinopathy. So I'm wondering about all of the non-inflammatory causes of joint pain. Are you guys just as well trained in detecting, I don't know, rotator cuff disease, osteoarthritis, and other non-mechanical causes of joint pain that can also be very useful to try to figure out what's going on?
So there's a long-standing history of diagnostic use of ultrasound in orthopedics and sports medicine. And certainly these specialties have kind of paved the way to use ultrasound for tendon tears and tendon damage. More recently, within rheumatology, there's been strong interest in enthesitis and inflammatory tenosynovitis, tendinitis. Certainly, a lot of the seronegative spondyloarthropathies, psoriatic arthritis, all of our inflammatory conditions that don't necessarily have lab biomarkers. Ultrasound is exceedingly helpful in identifying inflammation at the tendon insertion within the tendon body, or just visualizing, hey, they have a partial tear and that's what's causing the inflammation.
Fantastic. And I think another thing that's amazing about ultrasound is the ability to actually do something about some of the things that you see. So how do you use ultrasound therapeutically in clinic?
Let me clarify diagnostic use of ultrasound versus therapeutic versus using it for ultrasound guidance for procedures. Rheumatologists definitely use ultrasound guided procedures. We pride ourselves in being very good at the physical exam and doing joint aspirations and injections. Some patients have large body habitus and you don't necessarily feel the anatomic landmarks very well. And so ultrasound can be helpful in more accurate guidance for one, identifying that there is actually an effusion to aspirate, and then guiding the needle into the correct location to make the procedure less painful.
Are there any times where you don't use ultrasound for procedures, or you feel like once you're accustomed to using ultrasound, that's what you're going to be doing going forward?
Well, because my clinic is a subspecialty clinic here at Mass General, most of the procedures requested have already failed a palpation guided aspiration or injection, or the injection that's being asked may be not safe to do with palpation guided method. For example, the hip joint used to not be an injection that we would do in the clinic, but now with ultrasound can easily be done in the office.
Amazing. What do you think about the role of ultrasound for a treat to target approach? Like, yeah, I guess you mentioned, your patient with rheumatoid arthritis that continues having a painful joint and you're trying to figure out what it is. Or also even, patients that seem to be in remission and yet you see, Doppler signal on ultrasound. Is ultrasound helpful in those cases, or what's your sense?
So I know this is a highly debatable topic. In my opinion, yes, ultrasound is very helpful for a treat to target approach. Certainly, there are patients who report chronic pain and you attribute it to, oh, it was damage done. But then you apply the ultrasound probe and you see that there's active hyperemia or increased power Doppler signal, which suggests that there's still active inflammation going on at the swollen area that you perceive to be just chronic. Now, some people do have normal clinical exams on physical exam and they don't report pain. Then you apply the probe, and a few of these patients do have active power Doppler signal. What do you do with those patients? I think personally, I wouldn't necessarily escalate care if the patient is doing well clinically, inflammation markers are normal. But certainly if there's progressive damage in that joint, then you may think otherwise.
Fantastic. What's the difference when thinking about ultrasound, it's amazing that I can refer patients to you and you can, get them in. But sometimes there's a long wait. And I also have the opportunity to send it to interventional radiology to do similar procedures for diagnostic or therapeutic purposes. What do you think is the difference between sort of a rheumatologist doing ultrasound for either diagnosis or therapeutics versus, sending those patients to interventional radiology?
Well, it depends on the expertise at your center for radiology. So, musculoskeletal radiologists or general radiologists aren't necessarily educated about rheumatic ultrasound findings. They are much more familiar with the mechanical and orthopedic interventions or appearances. Certainly, if you're at a location where, the radiologist is able to do ultrasound guided procedures, that's certainly a good alternative. As far as like diagnostic applications by the radiologist, recall that it is a radiology tech that obtains the images. You do have to have a protocol in place, which if the radiologists are not aware of a specific like synovitis grading protocol that they've created for their tech, then they may not necessarily image the locations of interest for rheumatologists who's interested in how it applies to the patient's arthritis.
Amazing. Yeah. So it seems like if I want a left hip joint injection, IR guided is probably just as good as something that you can do in clinic. But for diagnostic purposes, to evaluate whether, there's synovitis or not, whether there's a power Doppler signal, whether there's maybe effusions are a little bit easier. I guess the experience of a trained rheumatologist in that case can provide added value.
And certainly radiologists also have limited time as well. They prefer to read the MRI or CT scan, which takes a few minutes rather than a tech doing the imaging. And then they are reading the imaging after the fact, so not necessarily in real time.
I'm sure there's a value in being able to evaluate joints with movement, right? Like I'm assuming that can provide you with added information.
Yeah. So what you're referring to is a dynamic ultrasound. So you can
That's
see,
what I meant.
yeah. So you can see tendon excursion and joints in motion. And I think the trained musculoskeletal radiologists also are very good at this. And, sports literature, things such as like snapping hip syndrome are things that can be evaluated. But again, it depends on the expertise.
Got it. So as a rheumatologist, what training do you need to become proficient in musculoskeletal ultrasound?
So the ACR curriculum for rheumatology, it was revamped a few years ago. Included in that was a supplemental curriculum for musculoskeletal ultrasound. So this provided a guide for fellowship programs that may not necessarily have their own musculoskeletal ultrasound curriculum in place to be able to follow a standardized curriculum if they chose to adopt it. A few years ago, US Sonar, the Ultrasound School of North American Rheumatologists, were actually working with the American College of Rheumatology in this ACR Train the Trainers program to try to identify a faculty member at each fellowship program so that there is at least one ultrasound trained faculty at every fellowship program. As of the most recent survey that we've done, I believe over 94% of fellowship programs have some sort of musculoskeletal ultrasound training in their fellowship program. I think, it's only a matter of time till we get to 100%.
Amazing. So does that training mean that you can go ahead and, start ultrasounding your patients on your own, or do you need some type of certification?
So there is a certification that was created by the ACR, the RHMSUS. This was actually a huge endeavor to try to standardize what a rheumatologist with ultrasound training should know. This was also to signal to payers and other specialties that this person has extra training specifically for musculoskeletal use in rheumatology. It does take a lot of additional training besides just being exposed to it in fellowship. It does require a lot of practicing on your own, learning your anatomy, learning your sonoanatomy. And there are various CME ultrasound courses that are available, including our own here at Mass General and programs through the U.S. Sonar Ultrasound School of North American Rheumatologists. The ACR also had their first standalone musculoskeletal ultrasound course in 2011. Prior to that, there were multiple professor workshops to introduce musculoskeletal ultrasound, as well as large vessel vasculitis, ultrasound for Sjogren's disease, ultrasound for interstitial lung disease, and ultrasound for myositis.
Amazing. So it sounds like there's several opportunities for people to learn about ultrasound. But I guess, just attending one of these workshops, I imagine is just, a piece of the puzzle. And you can't just go to a, 1 or 2 day session and sort of become experienced or proficient in ultrasound.
Just like any procedure, you need to learn how to do it, and you need to do enough of it to feel comfortable. And certainly to be able to pass the RHMSUS certification, it does require that you have a number of scans that you've done under your belt besides just passing the exam.
Got it. All right. Now let's talk a little bit about implementation. So you've had all this training, and now you have to somehow set up a way to do ultrasounds in your clinic. I understand that you developed the ultrasound clinic here at Mass General in 2011. Can you tell me more about that process and what it required?
Yes. So before I came here to Mass General, there was no musculoskeletal ultrasound clinic within rheumatology. I had to meet with actually all the stakeholders. So Department of Medicine, radiology, because one of the questions and concerns is, are you credentialed to do this? Is there a pathway to credentialing? So I basically had to write the credentialing pathway, write how and who is able to do what. Fortunately, here at Mass General, there was already point of care ultrasound with emergency medicine that has paved the way. So the American College of Emergency Physicians also include point of care ultrasound in their residency and have ultrasound fellowship training. And so I also met with them to see how they did it. And thus we created the clinic here. And then once the logistics of having the machine and being able to start figuring out how to bill so that you get reimbursed, then I had to let people know, hey, why do you use this? Who are the patients that we are looking for?
Got it. Was there any animosity between you wanting to do your own ultrasounds in clinic and the radiology department thinking that you're going to take some of their business away?
Fortunately, here, it was not that case. The chair of radiology is actually a big proponent of point of care ultrasound. So rheumatology is not the only POCUS program here at Mass General. Sports medicine, anesthesia, endocrine, there's multiple specialties who do point of care ultrasound within their specialty. The radiology chair here happened to have personal experience with the diagnostic use of ultrasound in one of their family members to identify partial tendon tear that was missed on MRI.
And how do you actually incorporate it into your clinic? I know for me, if I want to inject a knee or something, it takes me like 20 minutes to get all the tools together and actually do the procedure in addition to the time I'm spending with my patient. So, ultrasound takes a lot of time to do. Especially when you're doing procedures. Can you walk me through how you sort of try to address efficiency when doing a procedure or when doing a diagnostic ultrasound as part of your clinic day?
It's definitely challenging as you first start out. You're definitely slower with doing the procedure and setting up the procedure. But I think once you get experience, you learn how to efficiently have all the supplies, the consent, and everything that you need for the procedure within the clinic. Also, a good way to start out is actually just setting aside a half-day clinic for adding procedure clinics so that you can kind of get used to the flow. I have done so many procedures, I'm pretty facile, so I just incorporate it wherever throughout my clinic day. I do have more time than you, for instance, in your follow-up appointment.
Interesting. So how does that play a role in like RVUs and charging? Because, if you're spending more time with your patients, that means that you're seeing fewer patients. Can you sort of make up that lost revenue by billing and the fact that you're doing either diagnostic or ultrasound or using ultrasound for procedures?
Yeah, if you have high enough volume for ultrasound guided procedures, certainly it will make up for seeing less patients. I don't see less patients. And then as far as reimbursement for diagnostic ultrasound, unfortunately, it's probably not worth it. But from a clinical care standpoint and from the patient standpoint, it's very helpful in getting that information so that you're providing the best care possible in your medical decision making.
What about for procedures? Can you bill higher if you're using an ultrasound guided arthrocentesis or not?
Yeah, so there's a number of bundled ultrasound guided procedure codes. It does bill slightly higher than a palpation guided procedure.
But you think sort of at the end of the day, can you get more reimbursement if you incorporate ultrasound in your clinic, or is it about the same? Because it certainly takes time to do that.
It depends on how efficient you are. You can certainly implement it into your clinic so that if you're doing a certain amount of procedures, it's well worth the added time.
Got it. What do you think is the patient experience with using ultrasound? How do patients feel about the fact that you're plopping your gel and ultrasound across their joints? Is that something that they enjoy, or do they hate it, or what's your sense?
Yeah, patients absolutely love it. And in fact, there's multiple research studies that have noted patient satisfaction increases with the use of ultrasound. Part of it is probably the personal touch factor. They too are interested in learning about their disease. So if you're able to point out, this is why you're hurting, this is why you're inflamed, they're maybe more likely to take their medicine or consider medicine at all when they see that active power Doppler signal on the ultrasound. Pediatrics has also benefited from point of care ultrasound. So it's difficult to visualize joints in children without having to sedate them for MRI. And so ultrasound has been very helpful. And in fact, some kids who go to their pediatric rheumatologist regularly can scan their own joint.
That's amazing. We started this discussion and you mentioned that back in the day, ultrasound machines were like very big and not very accurate. Now I understand that there's some handheld devices. Can you tell me more about that?
As imaging quality has improved, technology has improved, ultrasound machines have become smaller. Now there's a number of pretty good handheld devices, including ultrasound with chip technology. So they're not using the traditional piezoelectric crystals. It's actually a computer chip that allows for ultrasound scanning. And this has also allowed for expansion of ultrasound teaching, tele-ultrasound, certainly places with difficulty accessing medical care, global health, rural areas. They can actually get a small handheld device and be able to show images somewhere else to an expert to help guide them.
Yeah, I mean, I was just thinking in many places of the country or of the world, an MRI may be totally unavailable, or a CT scan, maybe even x-rays. But I guess if you have somebody that's able to do point of care ultrasound, you can get, as much information practically at no cost.
Yeah, and point of care ultrasound is not just for musculoskeletal purposes. We are using ultrasound now in medical school education. This next generation of rheumatologists may have already had many exposures within medical school for learning different aspects of anatomy, pathophys. Certainly, the global health community has really embraced use of ultrasound, and ultrasound has even gone to space.
No
So,
kidding.
yeah.
Amazing. Are there any controversies in sort of musculoskeletal ultrasound? You hinted at one, which was, the sort of treat to target and what to do in people that are seem to be doing well, but have some evidence of power Doppler signal. Are there any other controversies in this field?
Well, I wouldn't say it's controversies, but there is this stigma of ultrasound is user dependent.
Mm.
And I think everything is user dependent. Even a pathologist who reads pathology slides, it's image recognition. You have to be trained appropriately to identify, the findings. The same is the case for ultrasound.
Yeah, absolutely. Where do you think the future of ultrasound is headed? I guess it's gone to space. What do you think, going forward, either in medical school or trainees using ultrasound to sort of learn anatomy and in patient care?
A few years ago, there was an update on the use of point of care ultrasound within the New England Journal of Medicine. And it detailed how point of care ultrasound has infiltrated every medical specialty. Within rheumatology, if you look at the number of research and education articles for musculoskeletal ultrasound from 2000 and beyond, it's been just going up and up. Part of the reason I think is because of improved technology and access to imaging and understanding what these imaging findings within our rheumatic diseases may be. We're still just brushing the surface on what we understand about all the different arthritides and rheumatic conditions. Imaging has been a great tool to be able to learn not only more about the disease state itself, but also how to monitor disease. I think everybody's been chat GPTing it, talking about AI, artificial intelligence. There's also use of AI interfacing with ultrasound. So as we use AI to identify patterns, within ultrasound, this may also become more available to the user because the machine may be able to lead you to, hey, there's an abnormality here, and it will highlight it.
That's amazing. And I can imagine that, in some future, not only will the AI help you to identify that there's something abnormal, but may also help you to make a more definitive diagnosis. Perhaps not just this is inflammatory arthritis, but this is the type of inflammatory arthritis seen in psoriatic arthritis or something like that.
Yeah, agree. And then there's other ultrasound technology that's of interest, such as ultrasound elastography, which actually uses sound waves to look at stress or strain on tissue. It actually visualizes how stiff the tissue is. So, for example, like if you were to be able to use ultrasound elastography in a scleroderma patient
Ooh.
and see different patterns of, how the skin changes, that would be pretty exciting.
Amazing. We pride ourselves in our ability to do a thorough physical exam. How do you think that your use of ultrasound has affected that? Do you feel like you've become less reliant on your physical exam because you trust your ultrasound more, or have you become a better physical examiner because of the use of ultrasound?
I absolutely think that my physical exam has become better because of ultrasound. I am able to actually see more subtle changes because I've seen the clinical correlation between the exam and ultrasound on multiple occasions. With that experience, certainly you can miss stuff. And sometimes I am surprised when I see someone who clearly doesn't look like they have any swelling. And then you look with the ultrasound and it is either swollen beneath or it's raging inflammation underneath.
Fascinating. And I got to ask you one last question. I hear you're a pretty good singer. US Sonar has a karaoke night. Can you tell me more about that?
Yeah, so at our recent US Sonar Fundamentals mid-course workshop, we had a karaoke night afterwards for the fellows to kind of unwind. We have a long history of a bunch of US Sonar faculty enjoying singing, and we often go to karaoke afterwards to celebrate.
That seems reason enough to join US Sonar and do MSK education.
We did see a lot of good singers that we were surprised came out of the woodwork.
Amazing. Minna, this has been most interesting, and I really appreciate your time and talking with me about ultrasound and certainly getting me and hopefully others excited about incorporating its use in rheumatology. So thank you so much.
Thank you. Thank you so much.
Well, there you have it. I'm so thankful to have colleagues such as Dr. Kohler who can use ultrasound to help me better take care of my patients. In another world, I would have liked to have taken advantage of MSK ultrasound training during my fellowship so that I could use it to diagnose and treat my patients in clinic. I also think it's particularly useful in pediatrics as it avoids sedation and radiation that is often brought on by other imaging modalities. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars or however many stars you think we deserve. You can find all our show notes for this episode and others on acronair.org, Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep bouncing those sound waves. And of course, stay healthy.